Hello everyone, welcome at SudhirEyeCoach, a channel for budding ophthalmologist. Today I'm sharing a surgical video on a patient with phacomorphic glaucoma along with an intumescent cataract. As we know, intumescent cataract have raised intralenticular pressure while phacomorphic glaucoma leads to elevated intraocular pressure. So in the preoperative phase, we manage the patient by administering anti-glaucoma therapy. To lower the IOL further, we have given mannitol infusion and ensuring the smoother and safer phacomulsification, and the proper anesthesia. Local anesthesia was also very important in such cases because patient's eye is inflamed and it gives a lot of discomfort and pain if we do not give proper anesthesia during surgery. Once the incisions were made, I filled the antechamber tightly with high viscosity viscoelastics to give proper compression over the capsule, and to further prevent the complications like Argentinian flag sign, I started by creating a small center nick in the capsule, then carefully extended it to the in a controlled manner. Instead of handling towards the periphery, I just created a small baby rhexis. Then I decompress the interlenticular pressure by milking out liquefied cortical matter. After controlled decompression, then I extended the capsular axis to the desirable size. In such cases, often we have a relatively softer nucleus, and phacomulsification was performed smoothly. After implanting the interlenticular pressure, I slightly adjusted the capsular size to ensure 360-degree coverage of IOL edges while avoiding excessive coverage of the optics. So this was a challenging case, and my aim in sharing this video is to highlight real-world surgical decision making. Every case patient presents unique challenges, and while there are different opinions on handling such situations, it's crucial to focus what actually happens on the surgical table. So watch this video, observe the technique, and I hope you find it helpful. Thanks for watching.